Close to 120 million Americans are walking around right now with high blood pressure. That's nearly 1 in every 2 adults. And the majority of them, more than 3/4, are on some form of prescription medication to keep it under control. But here's what nobody is talking about. The medications aren't curing anything. Every single year, more than 670,000 Americans die from complications directly tied to hypertension, heart attacks, strokes, kidney failure, and a shocking number of those people were taking their pills every morning without missing a dose. My name is Dr. Michael Kent. I've spent over 2 decades as a cardiac surgeon, opening chests, repairing hearts, and watching what chronic high blood pressure actually does to the human body from the inside. And I can tell you with absolute certainty, what most people are told about hypertension is dangerously incomplete. The story you've been given goes something like this. Your blood pressure is too high because there's too much fluid pushing through your circulatory system. Cut the salt, take a water pill, watch your numbers come down. Problem handled. Except the problem is absolutely not handled. That explanation is rooted in medical thinking that's half a century old. It's oversimplified, it's misleading, and it is keeping millions of people trapped in a cycle of managed illness. Their numbers look acceptable on paper while their cardiovascular system quietly deteriorates. The reality is that hypertension isn't a plumbing problem. It's a structural problem. It's not about how much fluid is in the pipes. It's about what's happened to the pipes themselves. In this series, I'm going to walk you through 4 specific biological mechanisms that create and sustain high blood pressure. Mechanisms that your prescription medications never touch. And then I'm going to give you a complete 4-step protocol grounded in published research that actually addresses these mechanisms at the cellular level. This isn't opinion, this is biochemistry, and it could change everything for you. Before we talk about fixing anything, we need to understand what we're actually dealing with. Your arteries are not pipes. They are living, dynamic, biologically active structures, and they are far more complex than most people, including many physicians, give them credit for. Every artery in your body is built from 3 distinct layers, each with its own function. The outermost layer provides structural support. The middle layer, called the tunica media, is made of smooth muscle cells and elastic fibers, and it's what gives your arteries the ability to expand and contract with each heartbeat. But the layer that matters most for blood pressure, and the one that gets the least attention, is the innermost layer. It's called the endothelium. The endothelium is a single layer of specialized cells so thin you could stack dozens of them and still not match the thickness of a sheet of paper. It lines every blood vessel in your entire body, from the large arteries near your heart down to the tiniest capillaries in your fingertips. And here's what most people don't know. The endothelium is not just a physical barrier, it's a metabolic organ. It produces chemical signals that regulate blood flow, prevent dangerous clotting, manage inflammation, and keep your vessels in a healthy, relaxed state. Now, coating the surface of this endothelium, on the side that directly contacts your flowing blood, is an extraordinarily thin protective layer called the glycocalyx. It's only a few micrometers thick. You cannot see it with the naked eye, but it may be the single most important structure in your cardiovascular system. The glycocalyx serves 3 essential roles. First, it creates a frictionless surface so that blood can move through your vessels without generating resistance or turbulence. Second, it acts as a molecular shield, blocking inflammatory particles from reaching and attaching to the vessel wall. Third, and this is critical, it senses changes in blood flow and sends signals to the endothelium to release a molecule called nitric oxide, which keeps your blood vessels open and relaxed. When your glycocalyx is intact, your vascular system works beautifully. When it's damaged, everything breaks down. And it is being damaged, right now, in millions of people, by 4 key forces: elevated blood sugar, chronic inflammation, oxidative stress, and cigarette smoke. These strip away the glycocalyx the way acid dissolves a protective coating. Once that protection is gone, your vessel wall is exposed. Inflammatory molecules attach to it. White blood cells accumulate. LDL particles penetrate the tissue. Plaque begins forming. Nitric oxide production collapses. Your vessels constrict. Blood pressure rises. This is the first mechanism of hypertension. Glycocalyx destruction and the endothelial dysfunction that follows. And not a single blood pressure medication on the market repairs it. Here's something your doctor probably hasn't told you. Your blood pressure reading, that 2-number measurement you get at every appointment, tells only part of the story, and in some ways, it tells the least important part. When most physicians see a controlled blood pressure reading, they consider the job done. But what those numbers don't reveal is whether your arteries are flexible and healthy or rigid and calcified. And that distinction, according to published cardiovascular research, predicts your risk of heart attack and stroke far more accurately than blood pressure numbers alone. This brings us to the second mechanism of hypertension: arterial stiffness, and calcification. A 2010 systematic review and meta-analysis, published in a major American cardiology journal, confirmed what vascular researchers had suspected for years. Arterial stiffness is a stronger, independent predictor of cardiovascular death than traditional blood pressure measurements. Let me explain what this means in practical terms. When your blood pressure is measured, you get two numbers. The top number, systolic, represents the peak pressure when your heart contracts. The bottom number, diastolic, represents the baseline pressure when your heart is at rest between beats. The difference between these two numbers is called the pulse pressure. In a person with healthy, flexible arteries, pulse pressure typically falls between 40 and 50. But as arteries stiffen with age or disease, something characteristic happens. Systolic pressure rises while diastolic pressure actually drops. You might see a reading like 162/72, giving a pulse pressure of 90. That wide gap is a clinical signal that the aorta has lost its elastic quality. It can no longer absorb the shock wave from each heartbeat the way it should. A pulse pressure consistently above 65 points strongly toward arterial stiffness. There is a direct, non-invasive test for this called pulse wave velocity, a measurement of how fast a pressure wave travels through your arterial system. In healthy, pliable arteries, that wave moves at around 6 to 7 meters per second. In stiff, diseased arteries, it accelerates to 12 to 15 meters per second. The faster the wave, the harder your heart is working, and the greater your cardiovascular risk. This test takes about 10 minutes to perform and is widely available. Almost no physicians order it routinely. The reason is straightforward and sobering. There is no pharmaceutical drug that directly reverses arterial stiffness. So within the conventional treatment model, measuring it provides no actionable pathway. But there is an actionable pathway, just not one that comes in a prescription bottle. So what causes arterial stiffness at the tissue level? And more importantly, can it be reversed? Let's start with the biology. The middle layer of your artery wall, the tunica media, contains two essential components: smooth muscle cells that actively contract and relax in response to your body's needs, and elastic fibers that allow the vessel to stretch and recoil with each beat of your heart. In a healthy artery, these two components work in coordination. The result is a vessel that functions almost like a second heart, absorbing pressure during systole and releasing it gradually during diastole, smoothing out the pulsatile flow into a steady stream. When chronic inflammation, elevated blood sugar, or sustained high blood pressure disrupts this middle layer, three destructive processes begin. First, calcium, a mineral that belongs in your bones and teeth, begins migrating into the artery wall. Chronically inflamed vessel tissue creates conditions that actively recruit calcium from the bloodstream. Once there, calcium crystallizes within the structural tissue, progressively converting what was once an elastic, dynamic vessel into something resembling a rigid tube. Second, the elastic fibers in this layer break down over time and are gradually replaced by collagen. Collagen is stiff and non-compliant. Every elastic fiber lost to collagen is a permanent reduction in arterial flexibility. Third, and this is perhaps the most striking finding, the smooth muscle cells themselves can undergo a pathological transformation. Under the right inflammatory conditions, they stop functioning as muscle cells and begin behaving more like bone-forming cells, actively depositing calcium into the vessel wall from the inside. A major review published in a top cardiology journal in 2019 established that this process, called vascular calcification, is the primary driver of arterial stiffness and carries a significantly elevated cardiovascular risk profile. By the time a person in their mid-60s has lived with poorly managed hypertension for a decade or more, their arteries can have more in common structurally with calcified bone than with functional blood vessels. And here is what conventional medicine still isn't telling most patients. This process is not necessarily permanent. There are specific nutritional interventions, backed by peer-reviewed research, that can actually halt and in some cases reverse arterial calcification. Not prescription medications, targeted nutritional strategies that work at the molecular level. We'll get to exactly what those are. But first, we need to cover mechanism 3. There is a molecule your body produces naturally that may be more important for your blood pressure than anything your cardiologist has ever prescribed. It's called nitric oxide, and it's not a supplement or a drug, it's a gas. A tiny signaling molecule produced by the cells lining your blood vessels. And when it's working properly, it is one of the most powerful blood pressure regulators in your entire physiology. Here's how it works. Your endothelial cells, those same cells in the inner lining of your arteries we discussed earlier, contain an enzyme called endothelial nitric oxide synthase, or eNOS. When this enzyme is functioning correctly, it converts a common amino acid into nitric oxide gas. That gas then diffuses outward into the smooth muscle layer of the vessel wall, signaling those muscle cells to relax. The vessel widens, blood flows with less resistance, pressure drops. When your endothelium is healthy, this process happens continuously. Your vessels are kept in a naturally relaxed, open state. Blood pressure stays in a normal range without any intervention. But when the glycocalyx is damaged, as we discussed in Part 2, enos function deteriorates. Nitric oxide production drops dramatically. Your vessels lose their ability to relax on command. They stay constricted. Blood pressure stays elevated. There's another layer to this that most people never hear about. The enos enzyme doesn't work alone. It requires a specific cofactor, a molecule called tetrahydrobiopterin, or BH4, to function correctly. When BH4 levels are adequate, enos produces nitric oxide efficiently and reliably. But when BH4 becomes depleted, which happens under conditions of oxidative stress, chronic inflammation, and elevated blood sugar, enos essentially misfires. Instead of producing beneficial nitric oxide, it begins generating harmful free radicals. The very enzyme meant to protect your blood vessels starts contributing to their damage. Now here's the part that gives me genuine optimism as a physician. There is a reliable, non-pharmacological method to stimulate enos and restore nitric oxide production. And it involves something as simple as how you squeeze your hand. A 2014 meta-analysis published in a sports medicine journal examined the effects of isometric resistance training on blood pressure. Isometric exercise means contracting a muscle without movement, holding tension, rather than performing a repetitive motion. The specific protocol that emerged from multiple clinical trials: squeeze a hand grip device at approximately 30% of your maximum grip strength, hold for 2 minutes, rest for 1 minute, and repeat this cycle 4 times. Perform this 4 times per week. The results, consistently replicated across trials: reductions of 8 to 12 points systolic after 8 weeks of practice. The mechanism is shear stress, the mechanical friction of blood moving across the endothelial surface during the hyperemic response after each isometric contraction directly activates the enos enzyme. Your body already has the hardware for this, it just needs the right stimulus. Now we arrive at the fourth mechanism, and in my opinion, the most underappreciated one. This is the explanation for why so many people reduce their sodium intake faithfully and see almost no change in their blood pressure. It's not because sodium doesn't matter, it's because something else is overriding the system that's supposed to manage it. Your kidneys are the primary regulators of blood pressure in the long term. They do this by controlling the amount of sodium retained in your body. More sodium retained means more fluid volume, which means higher pressure. Less sodium means lower volume and lower pressure. This is the physiology that the eat less salt recommendation is built on. But this system has a critical vulnerability. It can be locked in retention mode by a single hormone. That hormone is insulin. When insulin levels in your bloodstream are chronically elevated, your kidneys respond by holding on to sodium, regardless of how much or how little you're consuming. A landmark paper published in the New England Journal of Medicine in 1987 established a clear causal link between insulin resistance and blood pressure elevation. The mechanism works through multiple pathways simultaneously. Insulin directly stimulates sodium reabsorption in the kidney tubules. It activates the sympathetic nervous system, triggering a hormonal cascade that ends with aldosterone, a hormone that instructs the kidneys to hold sodium and excrete potassium. It also amplifies your blood vessels' sensitivity to angiotensin II, a potent vasoconstrictor that tightens vessels and raises pressure. The result is a kidney that behaves as though it's in a state of permanent fluid conservation, retaining sodium, raising volume, and driving blood pressure upward, no matter what you do with your salt shaker. And here is the part that catches most people completely off guard. You do not need to be diabetic, or even pre-diabetic, to have chronically elevated insulin. Your fasting glucose can be perfectly normal. Your A1C can be well within range. And yet your fasting insulin can be substantially elevated, silently driving your blood pressure higher every single day. Most physicians never measure fasting insulin. They measure glucose. They measure A1C. If those numbers look acceptable, they assume insulin metabolism is fine. It frequently is not. A 1991 paper published in Diabetes Care described insulin resistance as a multifaceted metabolic syndrome at the root of hypertension, obesity, abnormal lipids, and atherosclerotic disease. This connection has been replicated and expanded in the decades since. Fixing this fourth mechanism, resetting insulin sensitivity and unlocking the kidneys, is one of the most powerful levers available for normalizing blood pressure without medication. Now that you understand the four mechanisms, let's talk about correcting them, systematically and permanently. Step 1 is glycocalyx restoration. The goal here is twofold: stop the destruction and provide the raw materials for repair. The primary forces destroying your glycocalyx are blood sugar spikes and oxidative stress. Every time your blood glucose rises above approximately 140 to 145 milligrams per deciliter after a meal, a process called glycation, where sugar molecules attach to and damage proteins, begins stripping away this protective coating. The first objective, then, is blood sugar stabilization. Not diabetes prevention, blood sugar management. Specifically, keeping your post-meal glucose below 140 consistently. For most people, this doesn't require eliminating carbohydrates entirely. It requires making smarter choices. Whole food carbohydrates that digest slowly, non-starchy vegetables, legumes, certain fruits, produce modest, manageable glucose responses. Refined carbohydrates, white bread, white rice, pasta, pastries, sugar, produce rapid spikes that are damaging your vascular lining with each meal. The second objective is providing structural building materials for glycocalyx repair. The glycocalyx is constructed primarily from molecules called glycosaminoglycans, long, sulfated sugar protein chains. The most bioavailable dietary source of these compounds comes from sulfated polysaccharides found in certain seaweeds, particularly a compound called fucoidin, derived from brown seaweed species. Research has demonstrated that fucoidin supplementation supports glycocalyx thickness restoration and improves endothelial function. Studies showing measurable benefit have used doses in the range of 600 to 1,000 milligrams daily. The third objective is reducing oxidative stress, the chemical assault on your vascular lining that compounds the damage from blood sugar. The most effective dietary approach is substantially increasing your intake of polyphenol-rich foods, deeply colored berries, dark leafy greens, beets, high-quality dark chocolate, and green tea. These foods contain bioactive compounds that neutralize free radicals before they reach your vessel walls. A cup of mixed berries and 2 cups of leafy greens daily represents a meaningful and practical starting point for most people. When all 3 of these are implemented together, research supports measurable improvements in endothelial function tests within 10 to 14 weeks, and corresponding reductions in blood pressure as the vascular lining begins to recover. Step 2 addresses arterial calcification directly, and it's built around a protein most people have never heard of. That protein is called matrix GLA protein, or MGP. MGP functions as a molecular traffic controller for calcium in your soft tissues. When MGP is properly activated, it intercepts calcium that would otherwise deposit in artery walls and redirects it toward your skeletal system, where it belongs. When MGP is inactive or insufficient, calcium migrates freely into vascular tissue and crystallizes there. The key to activating MGP is vitamin K2, specifically the MK7 form, which has the longest half-life in circulation and the most documented effect on vascular calcification. Research published in the journal Atherosclerosis found that higher dietary intake of menaquinone, the family of compounds that includes K2, is associated with significantly reduced coronary calcification. The Rotterdam study, published in the Journal of Nutrition, found that this same dietary pattern corresponded to a reduced risk of fatal coronary heart disease. Without adequate vitamin K2, MGP sits in an inactive state, and calcium deposits accumulate unchecked. With sufficient vitamin K2, MGP becomes activated, and the calcification process can not only be halted but, in documented cases, partially reversed over time. Studies demonstrating measurable benefit have used doses of 180 to 360 micrograms of MK7 daily. But K2 doesn't work in isolation. 2 additional nutrients are essential to complete this decalcification system. The first is vitamin D. Calcium that is redirected out of arteries needs somewhere to go. Vitamin D facilitates the absorption of calcium from the digestive tract and its proper integration into bone matrix. Without adequate vitamin D, the calcium mobilized from arteries has no efficient pathway into bone. D and K2 work as a system. The second is magnesium. Magnesium is your body's natural calcium antagonist at the cellular level. When magnesium is present in adequate concentrations, it competes with calcium at smooth muscle cell receptors, preventing calcium from entering inappropriately and causing vessel constriction. It also inhibits the crystallization of calcium in soft tissue. Magnesium deficiency, which is extremely common due to depleted soil, high-stress lifestyles, alcohol consumption, and certain medications including diuretics, allows calcium to flood into smooth muscle cells and vessel walls. Supplementation with highly absorbable forms, magnesium glycinate or magnesium threonate, at doses of 400 to 600 milligrams daily, addresses this deficiency efficiently. The combination of MK7, vitamin D, and magnesium creates the biochemical conditions necessary to halt vascular calcification, redirect calcium appropriately, and over months of consistent use, measurably reduce arterial calcium deposits. We've covered glycocalyx restoration and arterial decalcification. Now let's complete the protocol with the final 2 steps. Step 3. Nitric oxide restoration. There are 3 specific strategies that work synergistically to restore nitric oxide production. First, protect the eNOS enzyme by ensuring adequate levels of its essential cofactors. The critical ones are folate, vitamin C, and vitamin E. These nutrients help maintain BH4, the cofactor that keeps eNOS functioning correctly and prevents it from switching from nitric oxide production to free radical generation. Food-first approach. Folate from dark leafy greens, vitamin C from citrus, bell peppers, and berries, and vitamin E from nuts and seeds. Research published in the Journal of Cardiovascular Pharmacology confirmed that vitamin C supplementation measurably reduces arterial stiffness in humans. Second, apply isometric training as a direct eNOS stimulus. The protocol described in Part 5, hand grip at 30% of maximum effort, 2 minutes on, 1 minute off, 4 cycles, 4 times weekly, is the most clinically validated non-pharmacological method for activating endothelial nitric oxide production. This is not general exercise advice. This is a specific protocol with a specific mechanism tested in multiple peer-reviewed trials. Third, and this one surprises most people, breathe through your nose. Your nasal passages are not simply air filters, they are nitric oxide production chambers. The mucous membranes lining your nasal passages and sinuses continuously produce and release nitric oxide, which gets carried into your lungs and absorbed into your bloodstream with each inhalation. Studies have shown that nasal breathing can increase circulating nitric oxide levels by up to 400% compared to mouth breathing during the same activity. Conscious nasal breathing during exercise, rest, and sleep, facilitated if necessary by mouth tape at night, is a zero-cost, zero-risk intervention with a direct and measurable effect on vascular function. Step 4. The insulin reset. The final step unlocks your kidneys and restores their ability to regulate sodium excretion appropriately. To do this, you must lower chronically elevated insulin levels. The most evidence-supported method for reducing insulin without medication is time-restricted eating, condensing your daily food intake into a defined window and allowing your body to remain in a fasted, low-insulin state for the remaining hours. For people with hypertension, a 16-hour fasting window with an 8-hour eating window has the strongest research support. A practical implementation. Eat between noon and 8 p.m. and fast from 8 p.m. through noon the following day. During the fasting hours, water, plain black coffee, and unsweetened tea are permitted. Nothing with caloric content. Published research demonstrates that time-restricted eating, without any other dietary change, can lower systolic blood pressure by 9 to 11 points within 8 weeks. The mechanism is entirely insulin-mediated. Lower insulin allows the kidneys to shift from sodium retention into sodium excretion, reducing fluid volume and normalizing pressure. To deepen and sustain this effect, resistance training is the most powerful tool available for improving cellular insulin sensitivity. When skeletal muscles are regularly challenged with resistance exercise, they develop greater density of insulin receptors and more efficient glucose uptake. Studies show that 2 to 3 sessions of resistance training per week reduces fasting insulin levels by 20 to 30% within 12 weeks. Together, time-restricted eating and resistance training don't just manage insulin, they restructure your metabolic baseline. Let's bring all 4 steps together, because this is where the picture becomes clear. Glycocalyx restoration, arterial decalcification, nitric oxide recovery, insulin normalization. These 4 interventions address the actual biological causes of hypertension, not the numbers on a monitor, but the structural and metabolic conditions that produce those numbers. When you address root causes rather than symptoms, pressure normalizes not because it's being artificially suppressed, but because the system driving it upward has been repaired. This is the difference between management and reversal. Management is a daily pill that adjusts a reading. Reversal is restoring the biological infrastructure that keeps blood pressure naturally regulated. Now, a word that I want to say very directly because getting this wrong could be dangerous. Do not stop your blood pressure medication abruptly. Do not reduce doses on your own schedule without guidance. Stopping antihypertensive medication suddenly can cause a dangerous rebound in blood pressure that can trigger a stroke or cardiac event. This is not a theoretical risk. I have seen the consequences of abrupt discontinuation in my operating room. What I am recommending is something different. Implement these protocols in parallel with your current medication regimen. Continue taking your medication as prescribed. Begin making the dietary, supplemental, and lifestyle changes outlined in these steps. Monitor your blood pressure at home, daily if possible, and track trends over time. As your numbers consistently improve over weeks and months, not days, bring that data to your physician. Work with them to evaluate whether a gradual, supervised reduction in medication is appropriate. Your improving blood pressure is the evidence. Your doctor is your partner in acting on it. Most physicians will respond positively to a patient who comes in with 3 months of home blood pressure records, showing a consistent downward trend alongside specific lifestyle changes. Give them data. Give them time. Make the changes first. The goal, the legitimate, achievable goal, is to reach a place where your vascular system is healthy enough that it maintains normal pressure on its own, without pharmaceutical support. That outcome is not guaranteed for everyone, and it takes time. But it is not the fantasy that conventional medicine sometimes implies it to be.